My name is Sarah Hicks, and I will be presenting a secondary prevention plan for a stroke led by DNP. This is a PowerPoint presentation for NU 712 Clinical Prevention and Population Health. The objectives of this project are to describe stroke disparities and risk factors in my area, also to define and describe the levels of prevention, particularly secondary prevention, which is the strategy we'll be using in this project. It's also to describe and detail a stroke prevention plan and the interdisciplinary team to enact that plan. Would also identify 3 DNP competencies dependent on implementing this plan in the community, and also the evaluation of the project. Stroke is the leading global cause of death after heart disease, and it's also the third leading cause of disability. Stroke is the second most common cause of dementia. There are 2 different types of strokes, ischemic and hemorrhagic. Ischemic, of course, these patients need to be seen immediately to get TPA or surgery, and hemorrhagic, these patients need to be seen immediately to prevent death. The TIA, these patients also need to be seen immediately. There is a common misconception in Alabama that if you have a TIA, you don't need to go to the hospital. They can also be indicators that in the next 24 to 48 hours, that person may be having a stroke, and if they do come to the hospital for a TIA, it could save their life. Looking at statistics that the Alabama Department of Health has put out in 2013 for stroke rates, the United States has a 41.8% stroke rate per 10,000 residents. In Alabama, it's much higher at 54.3. In Etowah County, the number just exceeds both of those. It's 66.8% of residents per 10,000 will experience a stroke. The risk factors for a stroke, there's modifiable risk factors and there's non-modifiable. I have detailed the modifiable risk factors on this slide. Of course, there's the hypertension, diabetes, tobacco, smoking, hyperlipidemia. There's those lifestyle factors that we try to hammer in our education, such as obesity, poor diet, physical inactivity. And then with this new generation, there's new risk factors such as technology. This is like sleep apnea, the use of e-cigarettes, and elevated lipoprotein is a big thing that physicians are starting to look at. Symptoms of a stroke include some sudden numbness or weakness, especially on one side of the body, sudden confusion or trouble speaking, or just understanding what people are saying to you, vision problems, sudden trouble walking or dizziness, and sudden severe headache with no known cause. Treatment for a stroke is then going to depend on the type. For ischemic stroke, we want these patients to have the opportunity to get TPA. It is the gold standard of treatment, but the patient has to be within a 3-hour window of when their first stroke symptoms start. The sooner TPA is given, the better the patient's chances of recovery and the reduction of deficits that they're going to have. Patients that have hemorrhagic strokes, they can decompensate very quickly because they're bleeding into their brain. So these patients need to be seen as soon as possible. For these patients, we want to get their blood pressure down as fast as we can. And of course, they may be going to surgery to get a drain or a craniotomy to resolve that bleeding. So I really want to focus on what happens when a patient does not get treated immediately with either TPA or just getting scanned so we can get blood pressure down and identify brain bleed. The penumbra is an area of viable tissue around the core of a stroke. The core of a stroke is already damaged, but the penumbra is that area that we have a chance to save. Every hour following a stroke or those first symptoms, 120 million neurons are lost. And so it's so important for us to be able to intervene as soon as those symptoms start. The Cincinnati Pre-Hospital Stroke Scale is basically what we want the community to use. It's what EMS uses when they arrive on the scene of someone who they suspect is having a stroke. Um, this is also the campaign that um, the Alabama Department of Health put out with the FAST, what to look for as far as symptoms of a stroke. Um, this scale is very effective and anyone can administer it. This is just that fast mechanism that goes with the Cincinnati pre-hospital stroke scale. And of course, that T is in time. If you have any of these symptoms, call 911 right away because we need to treat them. This is the stroke scale that we use in the hospital. I work at Grandview. We are a level 1 stroke center. We run stroke alerts every day. We give TPA on an average of 10 to 12 minutes door to needle time. The NIH stroke scale is what we use. It requires a little bit more advanced practice as far as what we're looking for. This is just the levels of prevention as detailed by the CDC. Primary is, happening before the health effects occur. Secondary is screening to identify the diseases in the earliest stages. And tertiary is managing those diseases. I'm going to focus on the secondary aspect of prevention for strokes. Of course, the primary aspect would be getting into those modifiable risk factors that we talked about, and the tertiary prevention plan would be getting these patients physical therapy and speech therapy as soon as possible after their stroke. So, like I said, we're just going to look at secondary prevention. We want to be able to identify stroke symptoms as soon as possible so that we can get that patient treatment time down. The purpose of this stroke assessment program is very simple. It's to equip members of the community with the resources that they need in order to identify and treat a stroke patient anytime and anywhere. JSU was really hammered in our BSN program. We want to empower and equip ourselves, but everyone around us to be ready to treat anyone, anytime, and anywhere. And that is what I am focusing on. The program design is really easy. It's just a two-step process that gives anyone the capability of triaging a stroke victim before they get to the hospital. It allows for easy 24/7 access to the stroke assessment scale. It uses the visual aids and tools in the Cincinnati pre-hospital stroke scale and ensures accurate information instead of, that patient says, hey, I've been feeling like this. Let me Google what's going on and getting a variety of answers, some of which would encourage them to not go to the hospital. So, like I said, this is just getting that Cincinnati pre-hospital stroke scale in the hands of everyone. This would just be an easy and a free way for people to have this. It's just a downloadable access to the scale. It can also be shared on social media. A big thing these days is you'll be scrolling and you'll see something and think, do I have that? Someone will share something on Facebook and you're like, maybe I should go see about that. There's been tumors and all sorts of diagnoses that have come from just seeing visual aids online. So this is the Cincinnati Pre-Hospital Stroke Scale that we would want to get to everyone in the community. A really simple way of doing this would be to get it out to schools, police stations, even training for EMS, pastoral staff. If they have their new staff training coming on, if they can just get this visual to these people in an email, their orientation packets, and they can have it on their phones at all time when they're in the community, when they're at work. They have access to this where they can triage victims. Um, this project in particular, I wanted to do something to where everyone could be a part of healthcare. Um, 2020, of course, with the pandemic, the biggest thing has been patients are more involved in their care now than ever, whether it's using telehealth, whether it's scheduling their own COVID test without a referral. So I said, why can we not do that with strokes? Um, we spend a lot of time on our phones and on various apps every day. If we were to have this Cincinnati stroke scale on our phones, then that enables any person in the community, in society, in a workplace, in a hospital to say, okay, these are signs and symptoms of a stroke. Let's call 911 right now. Um, so, of course, that team includes all of our healthcare workers, but it expands to the community and really enables the community and empowers them to have a little bit control over these strokes. The purpose of the interdisciplinary team, of course, is to create a safe pathway to treatment. The role of the DNP as program director for this course would be to be collaborative in communication and to manage this project, to reach out to those social pillars of the community, whether it be um, education, religious, municipal, whatever it may be, to just be a change agent and to get this program propelled. It may be going by the courthouse or going by a school or a preschool and saying, hey, here's this Cincinnati stroke scale. Can I just send this to you and you can send it out to your employees? The first DNP competency that we're going to talk about is systems thinking. It just talks about understanding the DNP's role in the community and establishing those important relationships. The second DNP competency is vision and strategy. This is important because it develops long term goals and strategies. And of course, we know that um, health is always evolving, and we always pray for we're going to know more and more about these disease processes, and particularly strokes. Um, and so, as that information is updated, the DNP would go and update that information in the community with those established relationships. The third DNP competency I want to talk about is just being a good business agent, being able to assess the needs. Is this an area of poverty? Are these people going to be able to use their phones to use this scale? So the evaluation of this program really relies on people using the Cincinnati Stroke Scale, remembering that they have it on their phone, saved in their photos, or saved as a file, or even saved on their Facebook or Instagram. Um, the questionnaire would be a link on the bottom of that scale that people could click on and fill out, even if, maybe there was an event where it led to them getting someone to the hospital. They could click on that link and say, hey, this saved someone's life. So just to summarize, of course, stroke is a leading problem in society as far as we have developed treatment, but the stroke patients that are coming in now are more complex. We have people coming in with seizures or these patients with dementia and Alzheimer's that we may not recognize a stroke in them necessarily. It's just so important to have a rapid assessment in the community of these strokes. Thank you so much for your time, and I appreciate you listening to this presentation.